Welcome to Unit 3B, which is covering contrast media and MRI, and this is covering Chapter 11 in your book. Please make sure you have your book with you and out during this video lecture because I will be referencing a couple of images that are in the chapter. Excuse me. So the first thing we're going to review really is image contrast and how that's going to relate to introducing contrast, injectable contrast or oral contrast to the patient. So we know that in T2 weighted images, any organs or any structures that we're imaging will have a higher signal if they contain water, because water is reacting to its T2 decay time, and it's also reacting to its relaxation times. And so typically on T2 weighted images, we're able to view pathology better. And that's mostly due to the fact that pathology will tend to have a higher concentration of water molecules due to edema, inflammation, etc. So in general, we're able to view pathology without the need for any type of extra contrast medium. But there are certain situations where using that extra contrast agent will allow us to increase the contrast of the lesions or the areas of interest by changing the T1 and T2 relaxation times of tissue. And so that's what we're going to be looking at today, is how imaging contrast, and primarily gadolinium, is going to allow us to do that. On this slide, you can see two images of a sagittal brain, and one of the methods that you might be able to tell from this particular couple of pictures is that they're using a rectangular field of view. And so we know that with rectangular field of view, we run the risk of aliasing. So when you're looking at these types of images, those are the kinds of things that you should be bringing up to yourself as you're analyzing or evaluating an image. You know, in your X-ray programs, whenever you guys graduated from X-ray school, I'm sure that image evaluation was kind of one of the bigger things of completing your requirements. In MRI, it's the same, except that since you're a technologist, it's kind of coming to you naturally because you've been trained to do it. But try to take a step back when you're looking at MR images and try to outline and differentiate between the different things that are noticeable on the images that you're evaluating. So for instance, on this slide, like I mentioned, we are using a rectangular field of view. So automatically you should be thinking about what are the consequences of using this type of field of view. Well, I'm running the risk of aliasing, or possibly, you know, other types of geometric issues. So start thinking about that. All right, let's go back to the pathology. As you can see on these two images, we are looking at pre and post contrast T1 sagittal views of the brain. On the pre-contrast image, as you can see, without paying attention to this image, when we're just looking at this image, you might have noticed a little bit of abnormality right up here, especially if you've been looking at brain MRs for a while. But to the untrained eye, this may appear as if nothing is wrong. And so administering contrast allows us to actually visualize this meningioma and how large it is, as well as the differences in the tissue characteristics within, which is indicated by the varying contrasts within the actual meningioma. And as a refresher, a meningioma is a condition where there is softening of the skull, there is going to be some bleeding as well as some fluid accumulation, and it causes pressure pushed up against the brain, and possibly pressure pushing up against the skull as well. When we talk about contrast, of course, there has to be a history involved in it because everything has a beginning, correct? So what initially occurred in MRI is that the pioneers, which, you know, when we think back on our first unit of our first class, the pioneers were Damadian, Purcell, even Tesla's considered a pioneer. So the MR pioneers in the 1970s, late 1970s, started experimenting with different compounds, different chemicals, different material that they could use as extra contrast. And they found that injecting manganese salt altered the magnetic relaxation times of tissue. And that gave them the aha moment where they realized that certain metals and certain material found in the earth, as well as that can be created, can alter the magnetic field. And by altering the magnetic field, it could alter the relaxation times of tissue. So in 1981, they had been experimenting with this different type of contrast agents that they could find. And the first person was scanned using a paramagnetic contrast agent. And so what they used was an oral contrast medium. It contained ferric chloride. And because it's oral, of course, we know that it is going to be enhancing the GI tract. And after a few years, gadolinium-based agents were introduced. And that was because through experimentation, they'd found that gadolinium-based agents improved specificity and sensitivity of various exams by making the pathologic structures appear much brighter and much clearer. When we talk about contrast agents, we have to understand how they work. And really, it goes back to the very beginnings of us learning about MRI, of the principles, really. So we know that image contrast in MRI is determined by the relaxation methods of different tissues and how those tissues interact with the magnetic field. So by us introducing contrast agents, what we're doing is we are influencing those relaxation times, the T1 and T2 times of tissues, by affecting the local magnetic field. So, and this is on another slide, but understand that these contrast agents are not necessarily influencing the tissue. Yes, they are being absorbed by the tissue. However, that's not what we're seeing. We are not seeing the absorption of that tissue. We are seeing the effect of the contrast agent on the magnetic field and how that effect influences the tissue's relaxation times. So MR contrast agents will contain paramagnetic or superparamagnetic metal ions. And of course, we're using metal ions because of the fact that they are attracted to and influenced by the magnetic field. And these metal ions are going to affect the signal properties of the tissue. So the two categories of MR contrast agents are paramagnetic and superparamagnetic, but you can actually break them down into kind of a subcategory. So paramagnetic substances are also considered T1 enhancement agents because they shorten the T1 relaxation times of hydrogen photons within the tissues. And of course, we know that shorter T1 times are going to increase the signal intensity on T1 weighted images. So when we're using paramagnetic contrast agents, which are T1 enhancement agents, we need to be aware that the images that we're creating should be post and pre T1 so that we can get the maximum benefit or influence of these agents. And likewise with superparamagnetic substances, which influence and shorten the T2 decay times of tissue, we want to make sure that we are using these with T2 scans or sequences. And T2 enhancement agents are going to make the lesions appear darker. So we're in essence kind of toning down the contrast, but making it significantly darker than the rest of the tissue. And that also brings out different characteristics of the tissue as well. So these are our two primary categories of MR contrast agents. So we talked about paramagnetic and superparamagnetic substances. Well, let's review what those magnetic properties are. Most of you have taken the equipment and methodology course where we talk about magnetism. If you haven't, this might still be familiar to you. So magnetism is a fundamental property of matter. So every every substance in the world that we know of has some degree of magnetism related to its moving electrons. When we're talking about magnetism as a fundamental property of matter, we are not talking about magnetism in terms of proton magnetic moments. We are talking about the entire substance as a whole and its ability or inability to be influenced by a magnetic field. When we discuss the fundamental property of matter, magnetism, we are talking about the influence of the magnetic field on the moving electrons. When we're talking about the susceptibility of a element or a substance to a magnetic field, we're talking more about its magnetic moments. When we're talking about MRI, of course. Hopefully that wasn't confusing. If it was, rewind it and listen to it again. So the general magnetism of a substance, it's the general fundamental property of matter. And there are 4 degrees of magnetic susceptibility for substances in general: diamagnetic, paramagnetic, superparamagnetic, and ferromagnetic. So those are the 4 breakdowns, and I've kind of spelled it out for you for how they interact with magnetic fields, as well as different types of material or substances that fall within those categories. Notice that gadolinium chelates, which is actually what we use. We do not use just straight gadolinium as a contrast agent. We use what's called a chelate, a gadolinium chelate. And so that's identified as a paramagnetic substance. So if we go back to our prior slide, you can see that paramagnetic substances are T1 enhancement agents and superparamagnetic substances are T2 enhancement agents. So that tells us that gadolinium is a T1 enhancement agent, at least for now, that's what we know. Iron oxide contrast agents are classified as superparamagnetic, which means that when we utilize an iron oxide contrast agent, we should be running T2 post-contrast sequences as well as pre-contrast sequences. And then, of course, we know that ferromagnetic are those that are the most highly attracted. So make sure you're reviewing this and refreshing your memory on which materials or elements are going to be found under each of these categories. So again, going back to how these MRI contrast agents function. In order for us to understand how the contrast agent affects the magnetic field and in turn affects the relaxation times of the protons, we need to refresh our memory about molecular tumbling. So tumbling of molecules is another term for wobbling. And so we know that as a molecule is spinning, it's also wobbling on its end, on its axis, so to speak. And so every molecule will wobble or tumble in the presence of a magnetic field if it is a spinning molecule. Not the nucleus, but the entire molecule is wobbling and tumbling. That's definitely a very important point to remember, is that we are influencing the entire molecule with our magnetic fields. Now, when a molecule tumbles at or near the Larmor frequency, then the T1 relaxation time of that molecule is going to be short or efficient. And the best example of that, of course, is our fat molecules, which they have a molecular tumbling rate that's very close to a Larmor frequency. That means that as the molecule is introduced to a magnetic field, its Larmor frequency is its molecular tumbling rate is very close to the Larmor frequency. And so when we are running T1 sequences, the fat molecules are going to produce a much stronger signal because they have been allowed to relax quite a bit before we push the next RF excitation pulse in. And as we recall, if a net magnetic vector is in the longitudinal plane before it is pushed into the transverse plane, the more it is in the longitudinal plane, the stronger our signal in the transverse plane will be, and vice versa. Now, the tumbling molecules are going to actually create fluctuations in the magnetic field. And to explain that, I need you guys to turn to page 375 that's in your book to figure 11.2. So figure 11.2, if you look at it, it looks like you have 4 different water molecules. Each one is next to a static magnetic field, or B naught, the main magnetic field. And at each of the 4 images, as you can tell, the water molecule is positioned in a different location, or a different phase, as you will. So on the top left-hand corner image, as you can tell, the water molecule is aligned with B naught, so it is parallel. To the right of that, the molecule is now perpendicular, facing to the right of the B naught, or the main magnetic field. The next picture down, the bottom right corner, the hydrogen and oxygen molecules are pointing down, or anti-parallel. And then to the left of that, the bottom left corner image, the water molecules are pointing left and perpendicular to the main magnetic field. Now, what this is pretty much explaining, and the paragraph underneath this image on page 375 actually breaks this down for you. But in essence, what this image is telling you is that as molecules tumble, they either add to or decrease from the magnetic field, the total magnetic field. So when we look at this image, we see that there is one instance where the water molecule is aligned with the magnetic field, and one instance where it's aligned against it, so anti-parallel. When it is aligned parallel with the magnetic field, it is adding to the magnetic field, the entire the total magnetic field. When it is aligned anti-parallel, it is subtracting from it. Now, when the molecules are perpendicular, they actually are not adding or subtracting. So what is this saying? It's pretty much telling us that the molecular tumbling rate, and therefore the molecular position against the main magnetic field, can either add to or subtract from the magnetic field. So in order for us to slow down the tumbling rate so that we can influence the magnetic field and make it either slower or faster, we have to influence these molecules to slow down. To do that, we use gadolinium. What gadolinium does is it alters the magnetic field and slows down the molecules of water, for instance, enough for them to start tumbling closer to the Larmor frequency. So as they're being slowed down due to gadolinium's influence on the magnetic field, they are going to actually create a stronger signal, and they're going to appear brighter on T1 weighted images. So if you think about what gadolinium is a metal. So as gadolinium is being introduced into the body, it is a ferromagnetic object, or technically it's paramagnetic, but it is still influenced by the magnetic field. It has a positive susceptibility to a magnetic field, and therefore it's going to alter the magnetic field. Just like if a patient had a metal implant, that metal implant would influence the magnetic field and alter it in some way. Well, gadolinium in specific doses will do that in a way that doesn't create an artifact on the image, but rather, if it does create an artifact, it's really just brightening the signal of the water molecules. So gadolinium alters the magnetic field, which in turn alters the speed of tumbling of the molecules of water. As they are slowed down, then they are now able to produce a signal in T1 weighted images. So when we're looking at these 2 images here of the axial brain, we have a pre-contrast T1 and a post-contrast T1 weighted image. Obviously, we can see that there is an acoustic neuroma, most likely here, or a ganglion cyst. It kind of looks like a ganglion cyst because of the shape and the edges being very smooth, but it's very close to the IACs. And so just from looking at these 2 images, I would assume that this is either a ganglion cyst or an acoustic neuroma. Typically, acoustic neuromas are going to be more inside of the IAC itself, but if they start at the very end, they could possibly expand out. So as we can tell from these 2 images, on the pre-T1, we can still see that there's something going on because it is a pathology. And T1, even though it's technically used to visualize anatomy, it will sometimes pick up on patho if it's significant enough. Now, when we go to the T1 post, we've injected gadolinium. We're still running a T1, so our fat signal is still high and our water signal is technically low. However, because we've injected contrast, we will see that there is a stronger water signal from areas that typically would not have been showing on T1. Notice how right in here where the sella turcica is, there's a little bit of fluid signal in the T1, not too much. It's kind of more of a fatty signal. But on the T1 post, we can see a whole lot more fluid showing up. Same with the eye socket. As you can tell, we can see a lot more of the viscous fluid as opposed to just the fat around the eyeballs. But also what you can tell is that there is this super bright contrast of yet another fluid area right here. So when we're looking at this image, we know that this is most likely fluid filled of some kind because it's showing up bright. And so with our deduction, our reasoning, we can assume that this is most likely a cyst as opposed to a neuroma. When we look at it here, we're thinking this could be a neuroma, this could be a cyst. But as we're injecting the contrast and we see this, we realize that this is most likely a fluid-filled cyst. So if the tumbling molecule with a large magnetic moment, which is the gadolinium chelate, is placed near a water molecule by injection, for instance, it's going to alter the magnetic field, and that's going to alter the tumbling rate of water. It's going to slow it down. It's going to bring it closer to the Larmor frequency. So therefore, the T1 relaxation time of the water spins is reduced, and the water in lesions is enhanced. So that's, in a sense, how gadolinium works in contrast mechanism. In MRI, we do use different contrast agents. The most common are going to be paramagnetic substances, and the majority of those are gadolinium based. However, and I wanted to align this and break this out more because this is kind of its own point. MRI also uses iron oxide, manganese, and tissue-specific agents, and these are not necessarily T1. We know that this is not T1 based. This is a T2 based contrast agent, but the majority of our contrast agents are going to be paramagnetic, and of those, the majority are gadolinium based. We will be talking about all of these today. If you look at this image right here, the OmniScan, this is actually one of the more older versions of what you might see in the clinical site. It's not being used as often. You might find it in hospitals, but a lot of the outpatient facilities have started leaning more towards using Dotarum or something like Dotarum, and we will be talking about why that is in just a little bit, but it has to do with the molecular composition of the actual contrast agents and how they're built. So with T1 enhancement agents, there are some things that we need to kind of be aware of. Paramagnetic substances, as we know, have a positive magnetic susceptibility. And of course, they are the most common type of contrast media that we use in MRI. Primarily, it's because the majority of pathology that we're looking at is going to be water-based, and it's also going to be much more visible against a T1 sequence rather than a T2 sequence. We also want to make sure that, super paramagnetic substances or agents are going to make lesions appear dark. And a lot of times the best way to visualize them is if they are brighter than the surrounding tissue. And so paramagnetic substances are what make the pathology appear brighter, and that is why they're usually the most commonly used. Gadolinium, like I said, is the most commonly used paramagnetic substance, and that is because it has 7 unpaired electrons. And so when in this slide I mentioned that gadolinium has a large magnetic moment, and so this is where we kind of discussed that a little bit on this slide that I'm on right now, if it'll move fast enough. So gadolinium has a large magnetic moment because it has 7 unpaired electrons. And these unpaired electrons have the magnetic moment 500,000 times that of a hydrogen proton. So when you think about how much more stronger that magnetic moment is, you can understand how one gadolinium molecule could influence the magnetic field enough to drop the tumbling rate of the water molecules. So the large magnetic moment is going to create that fluctuation that's necessary to reduce the tumbling rate of water and bring it down to Larmor frequency. So again, because gadolinium shortens the T1 time of tissue, including water molecules, it is known as a T1 enhancement agent. There are other T1 enhancement agents such as manganese, which is used to image the liver, and hyperpolarized helium, which can be used to image the lungs. Let's turn to figure 11.3 to look at this next point, which states that without contrast agents, some lesions are difficult or impossible to visualize. And you guys probably already understand this because you've seen these comparison images already. But on figure 11.3, you have 4 axial images of the brain, and the top image is a T1 no contrast enhancement. And as you can see, that patient has not been injected with any contrast. Now, we can already tell based on the pathology that there's something going on because it doesn't look right. But then once we inject the patient with contrast, not only does that bottom lesion appear brighter in that bottom left picture, axial T1 single dose, but you also notice that there's yet another lesion in the left frontal hemisphere area. And we did not see that on the axial T1 without contrast enhancement. And then we'll talk about the other 2 pictures in just a little bit, but just for now, notice the difference. When you have a patient come in with certain symptoms and you don't give them contrast, you might run the risk of missing a lesion that could possibly be the reason why we are experiencing the symptoms that they're experiencing. And finally, gadolinium can also be used to shorten T2 and particularly T2 star times. And I wanted to throw that out there because initially we talked about the fact that contrast agents can be broken down into paramagnetic and superparamagnetic substances, and that paramagnetic substances are T1 enhancement agents. And we also know that gadolinium chelates are paramagnetic substances. And they technically should be considered T1 enhancement agents because they are paramagnetic substances. But you can actually use gadolinium as a T2 enhancement agent depending on the type of dosage that you use. But primarily, you will find that you're using gadolinium with T1 based sequences. So when we're talking about gadolinium and other contrast agents and the influence that they have on the tissue's relaxation rate, what we're actually discussing is relaxivity. So relaxivity is the effect of a substance on the relaxation rate of a molecule. And one thing that you have to understand is that in MRI, we are not it's not that we are measuring gadolinium. We're not looking at the gadolinium contrast. So when we're talking about X-ray or CT, when you inject that contrast, you're actually seeing the contrast technically running through the system. The iodine is being picked up by the X-ray receptors of an X-ray or CT machine, and the cassettes or the image receptors. And so we're picking up that signal from the contrast because the contrast itself is dense and it's iodinated and it absorbs the X radiation and therefore it emits a signal. In MRI, that's not what we're doing. So it can be a little bit confusing, but it isn't really when you think about the mechanisms of how gadolinium works. So gadolinium is not actually being measured. We're not looking at the gadolinium that's being injected into the patient. What we're looking at, or what we're measuring, so to speak, is the influence of gadolinium on the substance by influencing the magnetic field. So recently, they have found that some gadolinium agents actually have a higher relaxivity rate than others at the same dosage. And that's where figure 11.3 again comes into play. If you look at page 377 again, we looked at the top picture and the bottom left. Let's look at the middle and the right picture. If you look at the labels, it says axial T1 post GAD double dose, and then axial T1 post-GAD triple dose. What that is that they have used gadolinium that is a double dose or a triple dose dosing standard. So when you're using a single dose, and we'll talk about dosage a little later on, you're giving the patient a specific amount, of course. With double dose and triple dose gadolinium and other contrast agents as well, you're giving the patient the same amount as far as the milliliters. But within those milliliters, there is double or triple the amount of gadolinium. It's not, as far as I have seen, caused any issues with absorption. But what it does is that it gives better visualization for pathology. That word is always so hard for me. And so it enhances the pathology at a much higher level. So if you look at those two bottom pictures, the bottom right and the bottom middle, notice how the bottom lesion, as well as the lesion in the frontal hemisphere, the frontal lobe, notice how they are enhancing significantly from the far left image through the middle image and then to the far right, single, double, and triple doses. And so notice how initially we have a pretty significant contrast on the single dose. When we go to double dose and triple dose, that contrast signal, the signal of the water molecules, is incredibly high. Now, sometimes it's not necessary, but as you can tell, by them administering double and triple doses, they've found a third lesion in the bottom right hemisphere towards the temporal area. And that's where the yellow arrow is. So we go from one red arrow on pre-contrast images to a red and blue arrow on a single dose. And then there's an extra a yellow arrow added on to double and triple, and they just get more and more enhanced as the dosage increases. And so one example of this type of contrast is multi-hands, and you may or may not have been able to use it in clinic. Some places use it, some places don't. But it does have a double dose or double relaxivity influence as compared to standard gadolinium that is single dose. So as you can see, the dosage as well as the relaxivity of the agent influence how it interacts with the magnetic field and therefore how it interacts with the water molecules. So let's talk about gadolinium. And in order for us to talk about this, I need you guys to turn to page 381. So gadolinium is a MR contrast that was initially available as gadolinium DPTA, and I'm going to try to say this, diethylene triamine pentaacetic acid. So this was the very first commercially available contrast gadolinium agent. And if you look on page 381, figure 11.5, at the very top left-hand corner, you can see gadolinium DTPA's molecular structure. Now, look through all of the different molecular structures that are present in all of these different gadolinium chelates that we can use. And notice how some of them are in a circular composition and some of them are in a linear composition. So whenever we are working with gadolinium contrast, the two main breakdowns so far that we've experienced in clinical MRI, the molecular breakdown of the molecular composition is either linear or what we call macrocyclic or circular. The circular molecules are considered macrocyclic, and they are composed or put together in a way to where they kind of envelop the gadolinium. Notice how on these macrocyclic or circular molecules, the gadolinium is in the middle and it's kind of surrounded by the other molecules. That is, in essence, what makes macrocyclic or circular molecules of gadolinium safer, because by the gadolinium being within the molecular structure, as opposed to looking at the linear ones like gadolinium DTPA and gadolinium DTPA BMA, the two top ones as well as the ones underneath them, you can see that gadolinium is not contained. It's there. It's in the middle, but there's nothing containing it in a circle of molecules. This comes into play with the blood-brain barrier. By having molecules of gadolinium surrounded by other molecules of sodium and oxygen and hydrogen, or of nitrogen, we actually have a way to keep the gadolinium contained, and it does not cross the blood-brain barrier and therefore does not deposit in the brain and cause issues down the line. That's why a lot of these new gadolinium contrast agents like doderum, for instance, are being touted as the safest, because technically they are not supposed to cross the blood-brain barrier. But of course, we won't know for sure if that's accurate until probably another 10 or 15 years when more studies have been conducted. But by looking at this image, we can see that gadolinium compounds or molecules are actually, the contrast agent has many different, and we are not technically taking gadolinium as a rare earth metal and injecting it into the patient. Now, as a rare earth metal, it has significant paramagnetic properties. And those paramagnetic properties make it very toxic. And if left in the body over time, can cause a lot of issues because it is a metal, and we don't need that kind of metal in our body long term. So what they found is that by chelating or chemically bonding other ions to the actual molecule, such as DPTA, which is diethylene triamine pentaacetic acid, that is actually holding the molecule together, chelating it and kind of surrounding it, making it less toxic, also making it less able to cross the blood-brain barrier. And that allows us to get that super enhancement of the water molecules without causing significant damage to the patient. So the paramagnetic properties of gadolinium affect the T1 and T2 relaxation times by reducing the magnetic field and therefore reducing the tumbling rate of molecules such as water. The gadolinium chelates, because that is what we're injecting, not just straight gadolinium, but the actual chelate itself, will shorten those T1 relaxation times, making them bright, making those tissues brighter. And they can also produce a negative enhancement for T2 relaxation times where they appear dark. The lesions or the water molecules appear dark. And that's why gadolinium can actually be considered both T1 and T2 agent, but we typically will use it with T1 sequences. So the effects of gadolinium all depend on different things, such as the type of contrast that we're injecting. Is it linear? Is it macrocyclic? Are we injecting it as a single dose? Are we injecting it as a double dose or a triple dose? How is it distributing within the tissue? Is there a higher concentration of certain types of tissue versus other types of tissue? And how does that affect the enhancement? What type of pulse sequences are we using? If we're using T1 pulse sequences, that means that our contrast is going to influence the images and make them appear brighter for pathology. If we're using T2 sequences, then we're most likely going to have a darkening of the lesions. And then also the magnetic field strength. If the field is a 3 Tesla, gadolinium is going to influence it differently than if it were a 1.5. And so those are all the different things that can influence and affect how gadolinium influences our images and our contrast. So we've kind of already talked about this macrocyclic versus linear composition. Again, make sure you're looking over these images to kind of understand what linear versus circular or macrocyclic is and how that contributes to the safety of the gadolinium itself. Gadolinium, after being injected, is water soluble, and so those chelates that and the reason it's water soluble is because of the chelates. By the chelates being the outside structure of the molecule, they are going to allow for the transmission or the movement of the gadolinium chelate from the structure that it initially was in into the intravascular space, and initially it starts to be eliminated through the blood and eventually through the urine, and within 24 hours about 98% of it should be gone. But the exact half-life of gadolinium chelates depends on how much we're giving the patient, as well as the patient's pathology and their GFR, their kidney function. patients that have renal impairment or kidney disease will have a longer amount of time of reduction or elimination of the gadolinium in their system. So blood pool agents are another type of imaging contrast that we use in MRI. To review, we are going to talk about gadolinium, which is the major or the most commonly used paramagnetic substance. And then we'll also talk about iron oxide agents, manganese-based contrast, and tissue-specific agents. But blood pool agents are actually another type of T1 enhancement agent that we can use to image the vasculature of the body, and that includes the heart, any type of strokes or bleeding, as well as any kind of permeability issues with capillaries. So blood pool agents actually stay in the intravascular space, and they stay there longer periods of time than gadolinium-based agents. Their half-life is a lot longer in the kidneys, for instance. It takes about 200 minutes to reach the half-life than it does other T1-based imaging agents. It is a macromolecular agent, which means that it is in that circular composition, circular molecular composition. And one of the most common ones that you'll see is Ablavar or gadophosphacet. And I have not actually used a blood pool agent before, but there are great benefits to using blood pool agents, especially when we're looking at small capillaries. When we're talking about vasculature problems, circulation problems, sometimes it's not the larger vessels that are the issue. Sometimes it's the smaller ones. And so blood pool agents allow us to extend the acquisition time for MR angiography images, and that is because they also influence the magnetic field, which also influences the T1 and T2 relaxation times of tissue. So let's look at how blood pool agents compare to regular gadolinium chelate. These two images right here are MRA studies of the heart and the aorta, as well as the branches off of the aorta and the branches into the lungs. And as you can tell, one of these has a more significant difference in contrast levels from the lungs into the heart and the aorta and the major vasculature. And this image right here has a little lighter contrast, a little more shades of gray, so to speak. But you can also tell that there's a lot more definition of these smaller capillaries and smaller arteries that we're looking at compared to this image. This is a blood pool image, and this is a gadolinium chelate image. And so if just by looking at these images, you can tell that there is a significant benefit to using these blood pool agents. But of course, we'll find out later on that in order for us to use any type of contrast, we have to make sure that the patient can actually get the contrast and tolerate it. All right, so some more major types of contrast agents used in MRI. Iron oxide is a super paramagnetic agent, which means that it is a T2 enhancement agent. It affects the T2 relaxation times of tissue. And there are two main iron oxide agents that are available for clinical use in the world. One is available in the US and the other, as well as other countries, of course. And then this one right here is only available in Europe and Japan. So ferrum oxide is an infusion style contrast agent where you actually have to give the patient this contrast over a long period of time, say maybe 2 or 3 hours. And then once the patient has had the entire infusion, then you do some delay phase imaging. You might do one image prior to, like a pre-contrast, and then you might start with an IV drip and take another image with delayed phase, and then take the patient out of the room, continue with the drip. So it's going to be the same type of phasing of image acquisition, except that it is going to be with the patient attached to an IV for quite a while. Now, ferrocarbitran is another type of iron oxide agent. We don't use it here, but it is used in Europe and Japan. And the way that it's used is by rapid bolus injection with dynamic and delayed phase MR imaging. And so it would be similar to what you currently do in the clinical site, where you are injecting with gadolinium and then taking immediate 20-second 1 minute, 2 minute, or 3 minute and 5 minute images for the liver. Both of these are used for liver imaging, for hepatic imaging, because these agents, these iron oxide agents, are processed in the liver. We know that the liver processes a lot of blood, and so that is why these iron oxide agents work best in liver imaging. Now, how do they work exactly? Well, because they're processed in the liver rather than the kidneys, we're able to look at the cells of the liver as this agent is kind of working its way through. And that's why we have this phased, multi-phase imaging, where we're taking an image immediately after injection, taking some sequences at the 20-second, taking some sequences at the minute, at the 3-minute, at the 5-minute. Those delayed images are actually because the varying layers of the liver take time to kind of process the blood as it's coming through. And so Kupffer cells, if you guys remember from anatomy and physiology, are liver cells. They're mostly found in the liver. You can find them in other structures, but they are mostly found in the liver. And they are the most uniformly distributed cells within the liver. And so for us to image them is quite easy, because we're able to watch as they are all taking up this contrast agent in a homogeneous and equal manner or time frame. So pathology that's very small or pathology that's very large can be visualized with these iron oxide agents very clearly, because of the fact that we're able to image all of these Kupffer cells uniformly in the different phases. And it does stay in the liver a longer time than gadolinium does. And so because of that, we can actually extend our acquisition time. So instead of it being 30 seconds or immediate 30 seconds, 1 minute, 3 and 5, it might be immediate 2 minutes, 4 minutes, and 6 or 10. It just depends on what the radiologist wants and what their sequence parameters are set up for. Oh, I'm sorry, let me go back. We want to look at this image just so I can explain it to you a little bit. So these are 3 images of an axial view of the liver and the spleen. Notice how large this patient's spleen is. It's incredibly large. These are images looking for what's called HCC, which stands for hepatocellular carcinoma. So that pretty much is any type of abnormality or malignancy within the liver. It's any type of hepatocellular carcinoma. So on the pre-contrast, you really can't tell anything abnormal. I mean, obviously we noticed that the spleen is quite large, but we also noticed that the liver is very, very large as well. But aside from that, we're not really seeing much abnormality. Now, this second picture is a dynamic breath hold post-gadolinium that shows a subtle HCC or hepatocellular carcinoma. And this is a T2 weighted image. And I'm assuming that they did some type of saturation technique, since the spinal fluid is not very bright. And then we look at image C, and we can tell that the lesion is much more visible than here. Here, really all we see is the outline. On the third image, we see the outline, but we can also see inside of the tissue. We can kind of tell that it's a pretty homogeneous structure. It's all the same cells, most likely. And so this is a T2 weighted image after they administered some ferric oxide particles. And that is an iron oxide contrast agent. And so it does enhance much better. And most likely these images were taken at a much longer time frame than this image was, to allow these lesions to fill with the contrast better. All right, so let's look at manganese-based agents. These are another type of contrast agent we can use in MRI. Now, manganese itself is the 12th most common element in the Earth's crust. It's also the 4th most widely used metal in the world, and so it's very abundant. In the body, if injected safely, of course, it enters the portal venous system, and it is passing through the liver from the GI tract. So it actually allows us to image the liver. 98% of absorbed manganese is cleared through the liver and excreted in bile. And so we're actually able to truly visualize how the liver functions, just like we would with an iron oxide agent. An example of a manganese-based agent is called mangafodipir trisodium. I have not utilized manganese-based agents. I don't know very many places that do. If you know of any, please share them with us. I have yet to find anybody that uses this. I feel like a lot of times where these types of contrast agents are most utilized would be in research facilities like, say, UT Southwestern, for instance, Baylor Medical Center in Dallas, BUMC. Those are probably the places that you'll find this type of imaging. So if we look at these pictures, these two pictures are CT images, obviously, and then this is our MRI image, and these are all axial views, just looking at the liver. If you look at these two images, we show a lack of enhancement in the portal venous phase, which is one of the phases of liver processing of blood. We can kind of see some type of abnormality here, but again, it's not really significant if we're strictly looking at just the CT images. So they run a T1 weighted image, an MRI, with a manganese-based contrast. They utilize the correct timing, and this massive lesion pops up. Initially, when the radiologist read the CT scan and saw this particular lesion on the CT scan, they did not identify it as malignant. They noticed it as a lesion, but they said it was most likely benign. However, after the injection of manganese, it was immediately identified as positive for a malignant lesion. And I say this and show this to say that it is important to experiment and to look at different methods of image acquisition, contrast agents. You know, this is why people tell you to get a second opinion, because most likely this patient went to one doctor and then either went to another facility that the same doctor requested a different exam, or went to a separate doctor who said, let's try something different. So it's very important to understand that this is not just about learning the material and passing the test. This is about people's lives. And that's what we're here to do, is to help save people's lives. And we are just as important in that process as the doctors and nurses are. All right, and the last type of tissue contrast that we'll look at is tissue-specific contrast agents. And so as the name indicates, these are contrast agents that are specific to types of tissues that we're imaging. And there's many different types that are going to depend on what we're studying, the anatomy we're looking at. And so one that I wanted to kind of bring to your attention and is in your book is secretin. Secretin is actually a natural hormone that's produced by our bodies in the glands of the small intestine. And this hormone stimulates the pancreas to produce its secretions. And so it kind of acts as a secretion agent on secretion agents. Now, the contrast that we can use in MRI can either be a synthetic form of the human secretin hormone, or we can utilize porcine secretions from pigs and inject those into the patient. Of course, they would have to be compounded into some type of agent that was safe for the patient. So secretin pretty much increases the ductal filling, and therefore the pancreatic duct is seen better. We are using secretin primarily for the pancreatic duct, as well as possibly the common bile duct. When we're using it in MRCPs, we're able to identify a much clearer image of the structures. Notice how on this top image, A, this is just an MRCP. There's no contrast. The only contrast we're using is the patient's own body fluids, for instance, the bile. In image B, we're using secretin. And as you can tell, not only can we see the pancreatic duct way clearer, but we can also see this smaller duct coming off of the intestine. And you can tell that you're not really seeing that as clearly on the regular MRCP. So again, a contrast agent is used to enhance structures and give us a much better view of something that we may not see without. So I did mention dosing in gadolinium. We have to make sure that we are dosing patients properly, both for their safety, but also for the clinical evaluation. If you give a patient too little or too much gadolinium, you may run the risk of either understimulating or overstimulating the magnetic field and therefore missing things. So we want to make sure that we are giving gadolinium based on the patient's weight, because they have found that that's the best way to determine what dosage works the best for patients. Higher relaxivity agents like those double and triple dose gadolinium agents are going to increase the signal intensity a lot faster with less dosage than, say, a standard single dose gadolinium agent. And so that definitely plays a role in it. But in general, the recommended dosage for gadolinium is 0.1 millimoles per kilo, and this is the unit of measurement for gadolinium dosing, or gadolinium chelates, of body weight. So what you do is you take the patient's weight in kilos and you multiply it by 0.1, and that gives you how much they're supposed to be getting millimoles per kilo of gadolinium or gadolinium chelate. A lot of times these contrast agents are going to come with like a chart you can hang up in your clinical site or your facility, and then you don't have to actually run this type of calculation. But if you're bored and you're at clinic and you know that you're about to inject a patient, run the calculation and see if it matches the number that's on that chart. And, you know, always double check those kinds of things. Another thing we'll talk about is lethal dose. So lethal dose is a term that's used across the board for any type of agent or substance. The lethal dose is abbreviated as LD50, and what it means is the dose that's required to kill 50% of a study population. So in gadolinium, the lethal dose, LD50, is between 6 and 20 millimoles per kilo. When you compare this to what the recommended dosage was, it's 0.1 millimoles per kilo. You should never get to this level. In fact, in clinical use, this level should never be used, but there are instances where somebody might have made a mistake or the dosing was improperly labeled. So you have to be very careful about what you're giving the patient. But this is the lethal dose for gadolinium. Now, per the ACR, and especially if your facility is ACR accredited, you must have a doctor present during any injection. Now, it doesn't have to be a radiologist. It can be a regular doctor, but there needs to be a doctor present during the injection. And there needs to be an order from the referring physician indicating that there needs to be contrast administered. You cannot just decide to administer the contrast yourself. So this is just a slide explaining what I talked about, which is the double and triple dosing and how dosing can affect images. So if you look at these two axial views of the brain, these are very zoomed in, small field of view, and we're looking at the lateral horn of the left kind of occipital temporal area. And they're pointing to these areas right here. This is pre-contrast, with a 0.1 millimole contrast, and this is with a 0.3 millimole per kilo contrast. This is considered a triple dose, and this is a single dose because this is the standard dose, and this is 3 times the standard dose. So it is a triple dose gadolinium. And notice how when injecting this triple dose, we actually get to see a lesion that wasn't visible on the single dose. So by using these higher relaxivity agents, we're able to identify lesions and pathologies a lot better with more specificity and more detail than without them or with lower dosage. So there are some that have been approved for 0.3 millimole per kilo dosage or as a triple dose, but you have to make sure that they are indicated as such. You cannot take a single dose contrast agent and give them a triple dose of it and assume that it will do the same thing. In fact, you would be giving them a pretty bad amount of gadolinium at that point. Those that are dosed as triple dose gadolinium, even though it's 0.3 millimoles per kilo, the molecular compound of that structure is different than a single dose. And so you are actually giving them a differently structured molecule that will interact with the body differently, that will be expelled from the body differently or at different rates. And so you don't want to just start playing doctor and tripling and doubling dosage. Now, if the radiologist tells you that they want to give the patient a little extra contrast or a little less contrast, that's up to them. But that's not the same thing as we're talking about here, because this is about the molecular composition of the contrast of the gadolinium chelate itself. All right, so we've talked about the types of contrast agents that we'll use, and we've talked about how they affect the magnetic field, which in turn affects the molecular tumbling rate, and that's how these gadolinium or contrast agents will influence our images. In order for us to actually give the patient this stuff, though, once we have a radiologist on hand, once we have the physician's order, we still need to be as the front line for these patients' health and safety. We need to make sure that we are taking and gathering the proper amount of information that allows us to determine if this is even a good call for the patient. The patient's medical history is something that we need to take anyways, just because we are medical professionals, and also to indicate any kind of MRI contraindications that may inhibit the patient from having an MR exam in the first place. We also need to make sure that when we're taking our patient history, that we are talking to them about any past contrast reactions they may have experienced. And this may be with MR-based contrast or even X-ray or CT contrast. Any type of reaction should be noted in their file. And then you should also be talking to the radiologist if the patient indicates that they've had a reaction in the past. When we're taking history, of course, we're going to discuss what types of exams they've had in the past, if they've had contrast. What's their medical history? Do they have diabetes or high blood pressure? Have they had a history of kidney or renal issues? Do they have implants in their body? And just making sure that we're writing down the list of everything involving safety in the MR suite. But of course, we can't solely rely on the patient history because the patient themselves may not know. They may not be able to communicate with us for whatever reason, and their family member may not be able to tell us what's going on with them. Or they're with a caretaker who doesn't know very much. And that is something that you'll run across very frequently. So when we are administering contrast agents, the most important test, in my opinion, or verification method is by using the GFR of the patient. And so we want to run a test to see how the kidney is functioning to determine whether or not the patient should be receiving contrast. So this is what we've talked about before. This might be familiar to you, but what we're talking about is how the GFR test affects whether or not patients are going to be receiving gadolinium. So most patients are going to tolerate gadolinium chelates fairly well because for the most part, most patients are healthy. However, in 2006, the FDA, and I don't want to say most patients are healthy, but most individuals don't have a severe level of kidney function failure or decrease. But in 2006, the FDA issued an alert about nephrogenic systemic fibrosis, which is abbreviated as NSF, and we've talked about this, of course. But as a review, NSF is a condition that is caused by the injection of contrast agents like gadolinium. Now, patients that have moderate to end-stage renal disease presented as one of the first cases that had this NSF situation happen. And then also patients that had stages 3 through 5 chronic kidney disease or acute kidney injury also presented with symptoms of NSF. And so the FDA issued an alert about it saying these are the patients that you need to be more cautious of when you are injecting any contrast agent. So GFR stands for glomerular filtration rate, and it is the rate of filtration of the functioning nephrons in the kidneys. How well are the kidneys filtering and expelling of these molecules, of these substances that are in the body? So it is an overall index of the kidney function, and it's pretty accepted across the general medical population as being a valid measurement. And how we do it is we draw a little bit of blood and we test that blood for the serum creatinine level within it. That serum creatinine level, along with the patient's gender, age, race, and weight, are inputted into a calculator that you can probably find online. Some places have like actual physical calculators. And it gives you what's called the GFR. So in most healthy people, the GFR is about 90 milliliters per minute or higher, which means that the kidneys are filtering at a rate of 90 milliliters of blood per minute. Now, once you reach 60 and below, these patients are considered in the more high-risk state, and they would be considered as having some form of kidney disease. It might even indicate that they have kidney failure or just a decreased kidney function. Once they reach under 15 milliliters per minute, then we would consider them to be in the kidney failure, or If they are on dialysis, then we would already know that they are in kidney failure. So this is the stages of chronic kidney disease. We start with stage 1, which is pretty much most of us, where we're above 90 or above in our kidney function. Stage 2 is between 60 and 89. 3 is 30 to 59. And then 4 and 5 are the most severe, which is 15 and under. Typically, with contrast agents and MRI, you definitely don't want to inject anybody with stages 4 or 5 because their kidney function level is incredibly low, which means that the gadolinium would stay in their system longer. We don't want that. The ACR says that those with stage 1 or 2 can get it without any problems, that we shouldn't even be concerned. But it does say that anybody that's in stage 3, we need to evaluate with a GFR. So if you run a creatinine test and you know that they are within a certain number, based on your constant work with this, you might already know they would be okay or not. Now, any patient, it says that any patient below 30 milliliters, you should have some precautions. A lot of places now have started changing their method of screening. Some places have gotten rid of the GFR testing. Some places have reduced the restrictions on it. I recommend that anybody that is under 60, that you kind of are more cautious with. Anybody that is under 30, you should be talking to the radiologist about. Even though some places say 30 and up is okay, I would still refer to the radiologist, especially if you're dealing with patients who are older or who have some other underlying conditions. And as a review, this is kind of how nephrogenic systemic fibrosis works. It thickens the fibrous tissue and the connective tissue in the body. With most patients who develop NSF, you're not going to see symptoms developing for weeks, if not months later. And so that's why we have to be very cognizant of what we're doing, because we are not going to be able to tell if we've caused damage until it's too late. Unfortunately, there is no cure for NSF, and it is deadly. Eventually, the patient will get to the point where all of their connective tissue and their organs have started to kind of thicken and harden up, and then they eventually die from just lack of being able to function. And so the best way to prevent NSF, since there is no cure, is to make sure that we are screening our patients by taking their history and measuring their GFR. I don't like the fact that a lot of these facilities are getting rid of GFR testing, but they're basing it on studies that they've performed. So I'm hoping that these studies are actually valid. So as we are getting the patient ready for their exam, if we're able to contact them ahead of time, it might be a good idea to tell them to be NPO for about 2 or 3 hours. Because some of the side effects of injection of gadolinium could be nausea and vomiting. And when you have a patient that is laying down on their back and they start to have a vasovagal reaction, you don't want them to aspirate and choke on anything. But of course, you want to follow your facility's best practice policies. So as we prepare the patient for the exam, we need to make sure that we verify their weight so that we know their dosage, as well as for SAR limits, because we do need to input that information into the console for RF safety. Also, we need to make sure we take their history, talk about their condition, what they're experiencing, explain the exam to them, discuss the fact that we're giving them contrast. Once you get all that information and you verify that the patient is able to get the contrast, you've ran the GFR, everything's good to go, then you should go ahead and draw up your contrast as your patient is changing. I don't recommend doing that while they're in the room because it freaks them out a little bit. Make sure that you know your dosage rate. Check your chart on the wall or do your calculation. And then, of course, if you're using a power injector, make sure that you know the rate of administration. You know, certain exams like pituitary have a different rate of administration than, say, carotids or the abdomen. So you want to make sure that you know the rate of administration. And that doesn't just apply for the type of exam. It also applies to the size of the vein that you're using. If you're using a smaller vein, you want your rate of administration to be slower so that you don't blow the vein. And this is when we're using a power injector, of course. Always check your expiration date on your contrast vials. Make sure that you are writing all the information down, like the lot number, expiration date, the name, how much you've given the patient, and then put that on the patient records, on their medical records, so that we know what types of contrast were used. So that if for some reason the patient in 6 months comes back and says they have NSF, you can go back to your chart and give information to the company that supplied you with the contrast so that maybe they can reach out and say, hey, don't use this contrast, it caused some issues. But overall, make sure you're protecting the patient and protecting yourself by covering your bases. So standard procedure for IV prep may include things like telling the patient what you're giving them, how it's going to feel when it's injected, what kinds of reactions to look for, so that if they feel something different, they're letting you know. Always make sure you get written or verbal consent for contrast administration, and always make sure that you complete your IV setup, if you can, prior to bringing the patient into the room. And then, of course, as a review, we have to make sure that there is a radiologist present or a doctor. But it's not just us who can inject. A radiology nurse can also inject the patient with contrast. This should be a review for you guys, but just to kind of refresh our memory about starting IVs. The best and most common IV administration sites are in the antecubital fossa of the forearm. There are 3 specific veins that we typically want to work with: the basilic, the cephalic, and the median cubital. The basilic is on the medial side of the forearm and elbow. The cephalic is the larger of the 2 in the antecubital fossa. This median cubital vein is typically smaller. So if you are using a power injector, I don't recommend using this one. I do recommend using either the cephalic or the basilic. If you have to use a smaller vein like the median cubital or one in the wrist or hand, make sure if you're using a power injector that you're reducing your rate of administration so that you don't blow that vein. And as just a comfortability type of suggestion, try to only use the non-dominant hand and arm when injecting, so that if there is an adverse reaction like a hematoma, bruising, pain, extravasation, that it does not affect the patient's dominant hand. When we administer contrast and MRI, we typically go 2 ways. We either do it with a butterfly bolus injection right before we run the sequences, the contrast enhanced sequences, or we use a catheter that we insert prior to starting the exam, and we connect that to a power injector and we inject via the power injector. So when you're using the power injector, some guidelines to follow include making sure that the vein is accessible and that all the air in the line has been bled out before you attach that line to the patient. So you set up your injector, you put the saline and the contrast in the injector, and you run them through and let the saline bleed all the way through the line and get that saline out of the line. Let it kind of flush out a little bit. And then you can connect that line to the patient's arm into the IV that you've started. And I would even recommend hand flushing the IV either with a small syringe of saline or with the saline from the power injector with your hand, and just making sure that the line is accessible and that you're not about to extravasate. Again, injection rates are going to vary by exam. Make sure that you're using the correct one. The reactions to gadolinium are really important to know. You need to know what to look for in a patient if there is a reaction. In gadolinium-based contrast, the reaction rate is very, very low. We don't ever see reactions to gadolinium. Typically, it's very uncommon, and it's usually because the patient had a reaction in the past. The most common things that you might see, however, are related to the injection of the contrast itself, not the contrast in the body, but the injection site. So bruising, hematomas, extravasation, infiltration, which is where you have it going into the wrong place, or a thrombus. Those are all things that you don't want to happen, but those are things that are more common with gadolinium injections. With contrast reactions, they can either be mild, moderate, or severe. And typically, you might see about 6 acute adverse reactions per 10,000 injections. And of 40,000 injections, maybe 1 would be considered a severe reaction. And so some of our more mild and moderate reactions include rash and hives, bronchospasm where they're having some trouble breathing, anaphylactic shock, which is kind of less common. It's not something that we really see too often with gadolinium. It's more with like CT contrast. Nausea, vomiting, coldness in the body after injection, or warmth or pain at the site of the injection. They might even say they have a headache or they feel dizzy. They might tell you they're feeling itchy. And a lot of times with these more mild reactions, they're not going to tell you until after the scan is over, because it's there, but it's not truly hindering them. You need to make sure that you report this. You go tell the radiologist, you let them know, and that it is put in the report as well as in their record. Because if a patient has a mild reaction the first time, most likely the next reaction would be severe and could lead to death. And that's across the board for any contrast. So if you ever hear a patient say, I had a reaction, even if it wasn't to MRI contrast, I would still discuss it with the radiologist. The severe reactions include respiratory distress and convulsions, arrhythmia, and then possibly unresponsiveness. And these would all require calling 911. Since we've talked about other contrast agents, we need to know how those reactions to those agents look like. Most of the time, they're all going to be the same. You know, you're going to have your itchiness, your vomiting and nausea. With blood pool agents, about a quarter of the patients that receive it actually report a reaction. So that's quite a high number. But most of the reactions are mild to moderate, maybe a little bit of rash or hives. Iron oxide agents, you're going to have a lot more pain involving the back, the groin, and the leg, but also some nausea, vomiting, diarrhea, and then possibly anaphylactic-like reactions. This right here would indicate possibly calling 911. Manganese agents, just some pain at the injection site, and then nausea and headaches. And then secretin is still being studied, but what they've noticed is that if there are any reactions, they're typically related to the pancreatic disease symptoms getting worse because of the secretin injection. We use gadolinium for everything, including brain, spine, and body imaging. We use it for pre-planning and post-operation, pre and post radiotherapy, any kind of infections of lesions, post-op studies, contrast enhancement for vasculature studies. So we use it for everything. And if you look at these images right here of the forefoot, we're looking at this little area of infection. It looks like a cellulitis. And on this pre-contrast, you can see there's some abnormality, but on the post-contrast, there's a lot more specificity of the different types of tissue signal. And so that tells us that this type of infection might be involving different types of tissues. And again, we can use contrast for angiography studies. With contrast use, instead of using, for instance, phase contrast, and this should be kind of ringing a bell for you from last unit, phase contrast is where we're using the flow of the molecules. So for instance, blood flow or CSF, and we're using that to create the image. That's a very lengthy process, and it can be, it can have some, difficulties with acquiring images. Contrast, when used with MRA, allows us to acquire those images a lot faster. We're able to identify the structure and create the super bright contrast in a very short amount of time. The most important thing to remember when you're using contrast with angiography studies is that you want to run a test bolus. And what that is just a small dose, maybe say 3 milliliters of contrast that you're running through right before you actually start the study, using some basic sequences to see if the contrast is actually showing up and that it is in the IV and that it's running properly. And then once you have that test bolus, you can also synchronize the timing. So you can see how long it takes from injection to appearance on the image. And then that way you can time the actual injection of your contrast for the actual study. You don't want to run the risk of injecting too soon or too late, because then you won't catch it. And so I recommend the first few times that you perform an angiography study with contrast that you have somebody there helping you, so that you're able to time it right. They can give you some tips. They can kind of be a second pair of eyes for you and get you more comfortable with it, because it is nerve-wracking. The first couple of times I did MRA carotids, I missed it, and it was awful. I mean, in the grand scheme of things, it wasn't too bad because the patient just had to come back in a few days. But it's embarrassing, and you feel like you didn't do a good job, which you didn't, and you feel like you failed your patient. And then you also have to inject the patient with gadolinium a second time, which is not ideal. You don't ever want to give them gadolinium unless necessary. So having to give them double dosage of it in a matter of the same week, for instance, it's just not a good idea. Especially if you're dealing with patients who have cancer, where their filtration rates in their body and their lymph system is already not working properly. You don't want to give them contrast more than they need it, because they already have so many other things going on. So just be very conscious of how you are conducting your exams. Take your time. Set everything up ahead of time. Make sure that you are talking to your patients throughout the study. I suggest when you inject the patient with the contrast that you keep your sound on. So I typically use the power injector for a lot of things. Of course, some things you don't have to, but I recommend that when you're using the power injector, that you turn on the sound to hear the patient as you're injecting them with the contrast, and just to kind of see if anything happens. If they're screaming or moaning in pain and the machine is running and your sound is off, you are not going to catch that. But it might be loud for a few seconds, but keep the sound on so you can see what your patient and hear what your patient is doing and feeling. And that way you can catch a reaction in its early stages as opposed to when it's gotten worse. All right, so make sure that you know the mechanisms of how these contrast media work and how they affect the magnetic field and the tissue, as well as the contrast on the images. We talked about screening and prepping our patients for the study, and making sure that you explain everything to them, as well as checking and double checking that they can actually receive the contrast. Make sure you're calculating your dosage properly so that you're not giving your patient too little or too much. Make sure that you are preparing everything before the patient is actually in the room. If you can, get everything set up ahead of time so that you're more clear-headed and calm. Know the kinds of contrast agents that are out there. Understand what you're using. Know if you're using a linear or macrocyclic. Understand the dosage of the contrast agent that you're using. Be aware of what you're injecting into your patients, and be aware of the types of adverse reactions that can occur and how they can be prevented. All right, thank you so much.